All right, thank you for staying with Daybreak. Now we're about to have a conversation on youth and leadership and what their plan is going forward. But before we do that, let me introduce my guest real quick. Honorable Reuben Kiborek, Member of Parliament for Mogotio and also Health Committee member. Thank you for making time. Nafula Wafula Gitonga, Director of Shindi Empowerment. Thank you very much for making time. Alex Matere is here as Executive Director, Youth Bridge Kenya. Thank you for making time. We're still waiting for Gabriel Kagombe, Member of Parliament, Gatundu South. If he comes in, we'll drop him into the discussion. But for now, let's talk about something here because Kiborek is a member of the Health Committee. Over 600 hospitals under the Rural and Urban Private Hospitals Association, Kenya, are giving notice that they will suspend services under the Social Health Authority, SHA, starting Monday next week. The association says that the decision follows the government's failure to clear 30 billion shillings worth of pending bills by NHIF and ongoing system challenges with SHA, putting thousands of patients who rely on private healthcare at risk. Now, should the suspension take effect, it will be a major blow to teachers and police officers covered under the Medical Administrators Kenya Limited. Emily Chebet has the details.
The lives of thousands of patients who depend on private and faith-based health facilities now hang in the balance. The announcement by the Rural and Urban Private Hospitals Association of Kenya, RUFA, to suspend service delivery under the Social Health Authority next week paints a grim picture of a struggling healthcare system.
Despite numerous engagements with government authorities, two critical issues remain unresolved, making it impossible for hospitals to sustain operations. Number one, the settlement of historical NHIF arrears amounting to Kenya shillings 30 billion. Number two, we reject the unworkable SHA outpatient reimbursement model.
Tumeiangalia na tukaona kwamba haiwezekani kupeana huduma za afya kutumia mfumo huo. Mfumo huo ambao unatoa shilingi 900 kwa kila member kwa mwaka, ambayo ukihesabu ni chini ya shilingi 75 kwa mwezi.
Private hospitals are a crucial lifeline, delivering 45% of primary health services and accounting for 30% of level 4 healthcare facilities in Kenya. These hospitals provide specialized care and ongoing treatment to over 1 million Kenyans, including those living with chronic conditions such as kidney disease requiring dialysis, diabetes, heart disease and cancer. According to Dr. Lishenga, hospitals across all ownership categories in Kenya are grappling with significant challenges. The latest SHA transition scorecard by the Rural and Urban Private Hospitals Association of Kenya, RUFA, reveals worsening dysfunction within the system. Research conducted in February 2025 shows that 89% of hospitals reported that the SHA claims portal remains non-functional, preventing them from processing reimbursements. 54% of hospitals have not received any payments from SHA since December 2024. Those that received payments reported no transparency on what the payments were for, making financial planning impossible. 87% of public level 2 and 54% of public level 3 facilities have not received any SHA payment since SHA transition began. 83% of hospitals reported serious difficulties in verifying patient eligibility due to SHA system glitches, leading to denial of care for patients in urgent need. 74% of hospitals reported being unable to reach SHA for claim-related queries, with calls and emails going unanswered.
How do you explain paying 75 shillings for a diabetic patient, a hypertensive patient? We know that our dialysis centers are collapsing under the burden of NHIF claims. It will be tragic that from Monday, you would expect dialysis patients to start going back to their pockets. This is not the situation we've wanted. We want to protect the sector.
The Rural and Urban Private Hospitals Association, RUFA, has joined other private health facilities in suspending services for teachers and police officers covered under the Medical Administrator Kenya Limited scheme, citing unpaid debts.
MKL has failed to pay hospitals for the last 1 year. No single hospital has been paid by MKL. MKL has been forcing hospitals to accept arbitrary and unexplained discounts on true claims. We also note that MKL happens to own its own clinics and that it has been favoring these clinics in an uncompetitive and unethical manner.
According to RUFA, at least 2 million Kenyans will be affected by the latest move. The challenges bedeviling the Social Health Authority continues, with patients, especially those with chronic illnesses, expected to face a myriad of challenges come next week when all private hospitals have declared no service for anyone under SHA. Emily Chebet, Citizen TV, Nairobi.
All right, Kiborek, you sit in the Health Committee. Are you aware of these challenges facing SHA?
Like I told you, Trevor, last time that SHA as a new baby has some small teething problems. However, most of the time, people want to take it to put pressure on it because they know it's a new baby in town. People want to put pressure on the same SHA to deliver like someone which has been here for the last 30 years. To be honest, Trevor, the bending bills they are talking about are for the defunct NHIF. There is no bending bill for the new SHA. But when they are reporting, it seems like it's bending bill from the same SHA. While last, the bending bill is from the defunct NHIF. And this week, I'm sure, because I sit from committee and we ask them questions, and we ask them tough questions when they come to committee. We don't. I think you have seen, because most of our oversight and our meeting with SHA, we always have citizen and other media houses which we allow them to come in, because the question we're asking in committee, we are asking on behalf of Kenyans. So we have nothing to hide in a closed door. So when we are in committee and doing our oversight, we are very tough at them because we want it to work. And this week they will be paying, they'll be paying money for up to 31st January 2025 in this week. That is for the SHA. But the bending bill, which is amount to, I think around that is something billion, belongs to the defunct NHIF, and which we had to ask them for the breakdown of this money. And it is a process being bending bills anywhere in Kenya. And it has to, we have to prioritize fast the services now as we look for the resources to pay the pending bill for NHIF. So speaking as if NHIF, if it will have been here, they will not be in those bending bill. It will have been here. And the bending bill will have been there. And the pressure about NHIF to pay pending bill will not be here. Because when something new comes, when something progressive comes, we are used to fighting it. We are used to want to show that it doesn't work. While last you know very well, and when he speaks there, he knows very well that the pending bill he's talking about belongs to NHIF, and the government has not refused to pay. Because majority of NHIF money came from Exchequer. And those money they are talking about, the 31 billion or something, or 32 billion, should be paid through Exchequer because of the funding model of NHIF, which used to be. Some of them, there's a period when contracting period was coming in with the NHIF, there's a period that, you know, there's a bending bill in a period where the NHIF, the contracting of NHIF had not come into place. So they agreed that this money will pay them, but it was not part of the NHIF, actually NHIF bending bill. It is the contracting period. When the contracting period of NHIF was being done, the people, they accrued. Yeah. There's some money which accrued at that period. So the pressure to just pay SHA as if it is a monster which is not working, which is here to punish Kenyans, is fake and wrong. Because
are the people Mogoti telling you that their SHA is working?
SHA is working.
Because you also represent the people
yes,
who go to do.
They are telling me when it is working and when it is not working. I have testimonies of many people who have been helped by NHIF, maternity, hospital, surgery, many people. I told you last time I have a patient who is going to India, given 500,000 by SHA. It is working. In some cases, there's some small. Yeah, even you can attest here, if you are to ask Trevor, that you have testimonies of people SHA has helped. And you have a small testimony of people who have issues with it.
And now the hospitals are saying, the pending bills you're talking about, the 54% of hospitals have not received any money since last year, but 2024, be that as it may.
There is only 580 facilities. Let me go to numbers.
Wait for the biggest concern, that the payments received have no transparency in what the payments are for. So even if you're going to pay, you're saying that next week they'll get some money, the hospitals don't know what the money is for, so they can't plan.
We have asked them, and their report is there is 580 health centers, health facilities, not shelters, whose payment were returned because of bank details not corresponding with SHA. You know, they don't tell you in their side also, sometimes their details do not correspond with those in SHA, and they were returned. And the number is 580 facilities. So, as we say, it is easy in this Kenya to bastardize everything and say it's not working. Whereas you also know there is testimony of people who have been held by SHA. You also know when they come to TV and talk with all blinking, they are saying there is pending bills, that they will shut down services. They are not saying the pending bill belong to SHA, it belongs to the defunct NHIF, which means the pending bill, and that is the reason why we moved from NHIF to SHA, because of such pending bills. It was not tenable to continue sustaining, paying NHIF through the exchequer. And it was going to, the pending bill were going to accrue more. It was going to be a big trouble, more than it is now. That's why we went to SHA, because of these pending bills, to be able to facilitate and fast-track the payment of this, the instant payment of, giving money to these facilities.
Okay. Nafula, what is your experience with SHA? What have you heard from the people?
Well, I'll speak as a citizen, right? As an ordinary citizen. Who has had loved ones that have had to dig into their pocket to be able to access healthcare in hospitals since the introduction of SHA. As a citizen, that is the only reality that I see, and that's the only reality that many Kenyans see, despite the squabbles, despite the conversations around, the system is new, we're just making it work. I think having a human-centric approach, even when you're thinking about the implementation of something like a health system, is very key. Right now, it feels like the health care of Kenyans is being treated as a huge experiment, and this prototyping and trying to make it work, behind them are people not accessing health and people dying. And so I think over and beyond the issues, I don't think Kenyans want to know these bills are coming from NHIF, this is what is happening. All I know is that, for example, I'm a tax-paying Kenyan and I'm not able to access healthcare from SHA for one reason or the other. I don't think it should be Kenyans' problems or Kenyan citizens' concerns as to what in particular, within the system is leading to this. Yeah, I think that means that the welfare of Kenyan patients was an afterthought. And for me, it just points to, it points to perhaps a failure in thinking through the process end to end, which is quite a gamble when you're thinking about the healthcare system of an entire country.
All right. Well, Matere, what are your thoughts on this?
Yeah, from where I sit, I think it's important for us to have a bit of background for the transition now from NHIF to SHA. And Trevor, you remember NHIF, the kind of challenges that it had considering the implementation. We also had cases where money was being siphoned, false claims that were there. We also had corrupt malpractices in the execution and payment of NHIF. And I think some of these reasons are the ones that necessitated our transition into a health system that would be able now to address all these challenges. That said and done, it's also true to admit from the point of view of my colleague, Honorable Kiborek, that there are two sides of the coin. There are also very good stories of people who have visited medical facilities and they have been served well with SHA. But also on the flip side, also there are challenges emanating from access to the system and also these pending bills that my friend Dr. Brian Lishenga is talking about. And I think going forward, what would be important is can we propose, even as the Parliamentary Oversight Committee on Health does their own oversight on SHA and require more information on how to ensure that SHA is seamless in terms of the services they are providing. Can we have a round table? Because if they are talking about a pending bill of 31 billion, can the private hospitals and together with the Ministry of Health or SHA sit down and have a conversation about it? Even if it's not SHA, Ministry of Health, can they have a conversation about it on how this money is going to be paid? Because I think from the hospitals, what we are hearing, if 54% have not had access to this to the finances, then basically it means that they cannot be able to operate. So how are we also going to ensure and guarantee that they have this money so that they can keep their services in operation? Yeah.
And Kiborek, as the Committee of Health, what do you recommend? Because my concern is as the committee, you seem not to acknowledge that there are a lot of challenges that need to be fixed first rather than defending the position. So, and you're the people that Kenyans are looking up to. So if you don't recommend that there are problems with SHA, then how can it be fixed?
We are on record, and I'm on record in this instance. I will say there are some teething problems, which are small problems here and there, which some of them are transitional problems. Like when you talk about the system, when you go to new system, there will be some challenges with the new system. And I think we have up to 95% real-time response with the new system. But, however, as a new system it has to come with some problem. Secondly, there is a big challenge of sabotage with this SHA. And the main sabotage from SHA is one from, like the hospital we are talking here, that they want to come out and paint SHA in a very bad image. And they don't want to acknowledge and to admit that NHIF was not going to aid us anywhere. NHIF was defunct as it is now. It had many problems, starting from corruption, which was a main challenge. The hospital used to conduit with the branch managers and claims officers and pay money for services which not rendered. And that is the biggest problem, because that loophole was sealed. It was a whole corrupt system from, claims officers to branch manager to those hospitals. You'll get one hospital which is in that floor, claiming they did, this thing we used to oversight, claiming they did 30 surgeries. And you cannot see any sign of surgery which has been done there, but they used to pay that. So when it came to close some doors on corruption, and when you close corruption, there's consequences to it. People have to fight back. And the main challenge when you see this hospital talking like this, it is some of them, their taps has been closed. And they have been rendered to be paid for what they have done because of the system and the real-time monitoring of the SHA. That is one challenge which SHA is facing, that it is facing sabotage. Two, there's an issue of demoralized staff somehow, because when it moved, it was clear that not the whole staff from NHIF will move to the new SHA. So when people are not sure of their fate and their certainty on where they will go, they tend not to be as productive as they used to be. So that challenge is a human resource challenge, which is there because of the staff feel like this new SHA we are not wanted or will not be there because of the SCAC approved lesser number of people who should work in SHA. So it becomes now a challenge when it comes to human resource. So those two problems are the main problem which facing SHA. But the main, like right now I'm receiving a text from someone, Mwesh, I have experienced the service of SHA. My wife, cousin, was paid off 540,000 surgery fee, and in the same hospital I met a patient from Mombasa who also benefited SHA for surgery. The only shortcoming is maybe in future limits need to be improved. So these are positive feedback from the people. And when we speak on behalf of these people who are talking positive. However, we also have a challenge, and I told you the biggest messaging which has painted SHA in bad picture is one, hospital which used to work with NHIF, which used to contribute to pay fake claims that they have a patient who has been surgery, they have gone through surgery and, these critical diseases. Yeah. Now that loophole has been closed. Okay. And then they speak now in protest of the same because their money minting has been stopped. So we are here now. So what do you recommend going forward? Because it's true, we've admitted that their system glitches. There are those who say it has worked, others say it has not worked, others say that the USSD code takes forever to come. So what do we do now? As the health committee, what are you recommending? Our recommending is to continue improving on the system, building on the existing system and improve it to be a real time. And we have asked them and they are on course. And I think in the next 4 or 3 months, it will be clear that the system will be real time and 24/7, and it will improve. And the OTP, everything will be up and running in the next 3 or 4 months. 2 is to build on the existing, to push on KEMSA, because this thing is built on referral. SHA, the DNA of SHA is on referral, that you don't need to go to level 6 to be able to be treated for a disease which can be handled in level 3. So one thing that we are doing also is recapitalizing KEMSA, so that there's drugs in the lower hospitals, so that a patient doesn't need to go to level 6 to be treated as disease can be treated in level 3. The challenge has been there's no drug in those hospitals. So we are starting one from recapitalizing KEMSA. 2, working with county governments to make sure that they also enhance the infrastructure of these hospitals so that a patient doesn't have to be referred, to ease pressure in the referral hospital. Number 3 is to make sure that equipment in this hospital so that we bring equipment into this hospital through what we call fee-for-service, to remove the mess which we used to talk about in certain MES, which was more of managed equipment system, to replace it with fee-for-service, in the sense that you bring equipment, you are paid only for service. You are not paying for equipment when it is lying in the hospital idle. When someone uses for an MRI, you are paid at that moment at a fee which is allowed. So in building on that whole system and the critical disease, which we are now funding through supplementary to enhance more money to the SHA for the critical diseases, to be able to improve the tariffs and to be able to assist in terms of, putting resources into critical and emergency diseases. Yep. So we are doing what should be done through Exchequer. We're also asking Kenya to register for SHA and pay on their bit. But to be honest with you, SHA is a game changer when we overcome the sabotage from especially those who used to steal, those crook who used to steal from NHIF. It's an issue of time and fighting that small pressure. People want it to be dropped. Sometimes when cartel want to fight, they put pressure through the people. They sponsor stories and headlines which are very screaming for people, government to drop, to go back to NHIF so that they can still continue stealing. So it's an issue of fighting back. Okay. With the crooks and cartel, which have really minted NHIF for far too long, especially hospitals in this town. Many will close shops, which are in level 5, which are in 5th floor, 6th floor hospitals, which are operating in above lodgings. You get an hospital on top of a lodging, which is, it has a record of 100 patients being paid, being treated and surgery being done in that hospital. When you sit there, you cannot see one. But in papers, they have a whole claim department. There are people who have record of claim department for patients not there. That was the biggest challenge in NHIF. That's why we are talking about this pending bill of that 1 billion. It shouldn't be there. Okay. And when they come to TV next time, Trevor, and talk about pending bills, ask them, are these bills for SHA or for NHIF? They are for NHIF. And it is the same reason we are running out of NHIF to SHA, so that we don't get to a problem where we have that 1 billion. Okay. Pending bill in future. So it will work.
But I see Nafula disagrees with this. But the reality is that there are people who find challenges with SHA. That's the reality.
That's true. It's true, as you say. As I told you, teething problem, there will be 1 and 2 problems which are a challenge, maybe one. And there's another thing we are working on, which has been a main challenge, and the Ministry of Health are working and the SHA are working on means testing. There have been a challenge about the bunches and the means testing. They are now working, they're doing it, and it will come back. It will come out later so that we reduce the payment for those people who are in the low level. So they were working on the means testing, which has been the main challenge with NHIF. The main challenge has been the means testing, which they are working on. When we sort that, we are up and running.
All right, I have to take a quick break unless Nafula has something to say on this.
Yeah, just very briefly. I think if something is so good, if this is so good, it wouldn't take me 15 minutes to try and defend it. And I think that's a problem that Kenyans are having. It feels like every time legislators sit down and talk about SHA, it's almost like a marketing game. And if it is good, if it is working, if it's so good for us, then why defend it so much, in so many words? I think the problem here is 3 things. I think there's an exercise of power over Kenyans. And by what I mean is there's no transparency, there's no accountability, and there's no buy-in from the different stakeholders. That's why there's issues with the different bodies within, we've seen conversations, or rather squabbles between the body in charge of doctors and, that in charge of clinicians in terms of, who has access to the system, who is meant to make approvals. We have challenges, in terms of people actually paying for SHA. Government is telling people, please pay. And for me, that shows me that there's a basic problem even with regard to getting buy-in from stakeholders. If this is a system that works for us, for Kenya, as Kenyans, why not ensure that the buy-in is there, as opposed to blaming each and every particular quarter that can possibly exist for why this system is not working, as Kenyans die. Yeah? So I boil it down to 3 things. Transparency. I think people do not know, honestly, how this thing works. People don't understand how SHA is meant to work. And definitely accountability issues there. These are pending bills from here. No, yes, they're just trying to destroy it because of, the fact that that there were holes in the
Fights back.
system. Exactly. And a complete lack of buy-in.
Okay.
Complete lack of buy-in.
All right. I have to take a quick break. When we come back now, we switch topics and talk about what we were here to talk about. And also, Honorable Gabriel Kagombe, Member of Parliament, Gatundu South, will be joining us in just a bit. Right? See you shortly.